back live. There we are. Okay. Thank you again for the invitation to be here. Hopefully we can share some of our information that we've been working on back home in the States. Whereas that was an excellent focus primarily on the unicompartmental knee arthroplasty, congratulate the team here on the results that you guys are achieving here, and the fact that you're being thorough and researching and providing the data that I think is essential to those in the audience who may be, questioning, okay, where's the data, where's the beef, as we say back home. So congratulations on that. So we'll talk about the total knee at this point. Again, just reviewing some of the new technology that we have, results in the published literature as it pertains to robotic-assisted total knee replacement, and then some of my own personal single surgeon joint registry data that we are in the process of collecting, massaging, and hopefully publishing at some point here in the future. So we'll talk about new technology, and this is, when I teach, this is one of my favorite quotes, and I think this is very applicable for when we look at should we be adopting new technology. And we should always look at new technology with a bit of a critical eye, so that if something is not as we expect, that we're not too far down the path and we can no longer change. So make mistakes slowly is my caveat for the day. So new technology, we talked about this yesterday. It's been emphasized a lot this weekend, ranging from navigation to sensors to PSI, and now to our focus on robotics. And again, when we're looking at our data, whether it's uni-knee, total knee data, or hip data for that measure, really what we're doing is applying a measurement system to our outcomes. And measurement systems are, as the engineers will say, about accuracy and precision. So that's really the terms that we want to focus on. But these are the parameters, both objective and subjective. Subjective will be on the next slide, that we can look at to see, hey, how are we really doing when it comes to this new technology of robotic-assisted total knee replacement? So that ranges from, are we having complications, to how do our x-rays look, or more importantly from our patient standpoint, how do they feel about their new knee? Is it what they expected? Are the objective scoring systems, are they demonstrating that we are in fact helping them, as opposed to just being able to share anecdotal or empiric evidence that's not rigorously tested based on measurement systems? So any of the new technologies, what are the results? I think that's a fair question that all of us should ask, because we know that the highway of orthopedics is littered with lots of good ideas that look great in the laboratory, but in real life maybe didn't pan out quite as well as we would have expected. So we don't want robotics to fall under that category. So if we look at new technology and break it down into these three segments, I would tell you that this part, as I talked about yesterday to some degree, has helped us to a limited degree based on what our patients are telling us, okay? The x-rays may look better, but the patient satisfaction scores have not increased with any of these modalities. The kinematic sensors, the data is there to say, yes, the patients are getting better outcomes. As I showed yesterday, lower manipulation under anesthesia rates, better patient-reported outcomes. And then we go into the robotic aspect, which hopefully we'll be able to show objectively, using these measurement systems, that in fact the patient satisfaction scores are in fact going up. Okay? So I would argue, as I did yesterday, I'll say the same thing, repetition helps with learning, I've always found, that with our robotic technology and techniques, that we can truly assess what the navigation folks are able to do and what the kinematic sensor technology can do, which is address kind of a hybrid of component position as well as soft tissue balance. Okay, so it's really that measured resection and the gap balancing that I tried to demonstrate to you guys in the live surgery this afternoon. Hopefully that showed you some of the power of the system in terms of how you can use the technology that's right in front of us on the screen. And as I also mentioned yesterday, this is really just the initial foundation for what's going to happen in the future. Because, again, if somebody wants to update hardware, like with navigation or an implant system, that's very time-consuming. It's very expensive. With a platform like this, it's really a software update, which is why Smith & Nephew, even in the short period of time that the total knee application has been out, 14 months, we're already 2-3 generations down from what the engineers went and showed us 2 years ago. So it does not require huge cost money. It doesn't require hardware changes. It just requires updates to the software, and that's very powerful. So this is a quote from last month's Journal of Arthroplasty, Richard Malloy, and basically acknowledging the fact that robotics are everywhere, and they're going to be in even more places. And those of us that are open-minded to this technology and willing to embrace it in our operating rooms, it's not to say that we're on this leading cusp of technology. It just means that we recognize that technology can help us become better surgeons, which is better for our patients. So how does robotic-assisted total knee arthroplasty compare to the others? Again, what's the data show? And I'll be the first to acknowledge I've stood in this position numerous times over the last couple years without a whole lot of objective data to share. We now have data here from Pune. We have data from Arizona, where I am, and we're starting to see the objective data come out both in the podium presentations like this, poster presentations, and in the peer-reviewed literature. And that's what we really need to show, is this technology truly delivering on some of the promises. So let's just go through a couple of the articles here. This is Song analyzing the RoboDoc, which is really has limited application at this point, but basically showing that postoperative alignment outliers were reduced and the gap balancing was reduced in a simultaneous bilateral circumstance where conventional instrumentation was done on one side and robotic assisted on the other. Then we go to Klopas' study from last year, looking at the safety of it. In other words, what happens to the soft tissues when we bring this high-speed burr into our surgical field? Is that safe for our patients? Are we exposing them to added risk, per se? So this was a cadaveric study, 6 robotic-assisted and 7 conventional standard instrumented totals, and they actually showed more soft tissue damage, interestingly, in the conventional instrumented total knee as opposed to the robotics. So that confirms what I would call some of the safety concerns. This is a study that has not been published yet, but is out in electronic the media, and that shows increased precision in the coronal plane, in other words, the varus valgus and the limb alignment in the robotic-assisted population. Another soft tissue study, this is Haddad's group out of London, again looking at the soft tissue concerns, and again reduced bone and soft tissue damage when compared to conventional jig-based instrumentation. So peer-reviewed data that's showing that our technology, what we're using in the robotic-assisted world, is safe. And this is a patient-reported functional study, again by Haddad's group, looking at the early functional recovery. In other words, the first 6 months, I think, was their outlook. And basically what they showed was that in a group of 40 robotic versus 40 conventional, that they had diminished postoperative pain, narcotic requirements, less physical therapy sessions required, shorter time to straight leg raise, independent straight leg raise, and shorter length of stay. So across the board, they were seeing improvements, and the only change from one group to the other was the addition of robotic-assisted technology. As was mentioned yesterday, the Journal of Arthroplasty, both the July and August versions, have excellent articles about robotic-assisted total knee arthroplasty, unicompartmental knee arthroplasty. So I would encourage everybody to make time to read those articles. I think they're very powerful. They identify some of the concerns that have been talked about already at the meeting this weekend. So in this study or article by Jess Lahner, who's been one of the pioneers of robotics, he identifies these variables that we're trying to achieve, and he admits that that the technology is perhaps more convincing in the uni knee population than it is in the total knee, but that he sees advances that are on the horizon that will allow the total knee to kind of catch up to that same accomplishment. Brian Parsley had a little editorial in the Arthroplasty Journal, again, just looking more historically when robots started in the orthopedic operating room and looking ahead, saying really there's no reason to expect that this is going to be an expanded footprint across the board. So that's pretty much what's out there in the objective data. Okay, that's a fairly short but admittedly exhaustive review of what's out there, because that's all there is right now. That will be changing as more of us in the arthroplasty world have embraced this technology and want to show that what we're doing is in fact improving outcomes. So I'm going to share with you some of my personal experiences. So for background purposes, I actually started as a Mako user about 5 years ago when they just had the Uni-Knee platform. They were really the only player in the market, and that's what I started using in 2013. Our hospital is one of the few hospitals in the world that has both a Mako and a Navio. Took a little coercing, if you will, to get my hospital administrators to put down more capital investment to get a second robotic platform when they already had a robotic platform. But we managed to convince them that the Navio platform is really the next generation of robotics. So I converted my Uni knees to the Navio platform in early 2016. I did my first total knee with Navio January of last year, so more than 18 months ago, as part of Smith & Nephew's limited market release. That was somewhat bulky software, I'll have to say. A formal FDA approval came about in May last year in the United States, and we've done about 200 plus cases now with the Navio total knee. So does that make me an expert? I don't think so. It just means that I have a little bit more experience than some of my colleagues. So that's what I'm going to share. So what I'm going to share with you now is based on 200 cases at this point. So we've done about 500 robotic-assisted cases in total. But my son is a very avid Star Wars fan, and I like to tell my patients that robotics at this point in time is not R2-D2 and C-3PO, and we're not Luke Skywalker. Okay, we might think we are, but we're not. We're not quite there yet. But there we are. So we've analyzed our first 200 cases, and these are just the demographics. I would say fairly representative of a standard total knee practice. We had a few more females than males, but otherwise the demographics were quite consistent across the board from what I've seen over the years. So with this introduction of robotic-assisted technology, I look at it from four prongs: safety, reliability, efficiency, and efficacy. And I think each one of those deserves attention in terms of focused research, and that's what we just heard on the uni knee side, and I'm going to share kind of a similar approach on the total knee side. So let's look at safety first. So I looked at my first 100 cases, and basically we saw no complications with the introduction of a high-speed burr, pins in the operating room. So no pin track infections, no pin site fractures, no neurovascular complications. We did have one deep infection, one gal who fell 2 weeks after surgery and fractured off her lateral femoral condyle, and 2 patients who went on to need manipulation under anesthesia. We then added the next 100 cases to that cohort. Again, no complications related to the new technology. That's what I need to emphasize with you. We did have one late hematogenous infection. I wouldn't attribute that at all to our technique. Obviously, that was just bad luck on the part of the patient. And then we added one manipulation under anesthesia. So we had 3 manipulations. But again, no complications related or patient harm related to the robotic technology. So to me, you know, when we really didn't have precedent, I couldn't go to YouTube and find somebody doing a Navio total knee arthroplasty to teach me how to do this. I was pretty happy with the fact that we were able to bring this into my operating room safely, and I felt confident that I could then turn around and tell my patients, hey, this is new technology, but this is what we've seen, that it's very safe for you. We're not adding risk profile that we need to discuss or disclose to the patient. So let's move on to reliability, because we have new hardware, new software that comes in. So we've looked at, again, our first 200 cases, and we have 5 cases in which we had technical challenges. In other words, cases where my blood pressure went up. That's what it comes down to, right? So we had 4 software malfunctions and 1 burr malfunction. Of those 5, 2 cases had to be abandoned because we could not correct the challenge. All right, so that means 2 cases out of 200 in which I could not finish with the robotic-assisted technique. But in the last 95 cases, so after I had the challenge on case 107 with the burr malfunction, we have not had any issues with software or hardware that has stopped me from completing my robotic-assisted technique. So from that standpoint, I would say from a reliability standpoint, the engineers have designed and written software that works, algorithms that don't crash, computer programs that work smoothly, and we can really say that this is reliable technology. But we'll all have some technical issues, and that's why we have support in the operating room to solve those challenges. Let's look at efficiency, because this is something that was asked yesterday, and I think it's appropriate to ask this question. What is this going to do to my operating time? How am I going to get my cases done if I have a list of 8 cases, or as you guys here in India have 15 or 20 cases on for the day? You know, can I actually get through the day if this new technology comes into the OR? So what does this learning curve look like? So first of all, in order to address that, we have to define what we're measuring. Okay, we can measure surgery time, and everybody's idea of what surgery time looks like is different. And the same with what I call Navio time. So surgery time in my operating room, and how I measure this, is when I put the scalpel to the skin to the time I close the capsule. Okay, that's the part of the surgery that I do every time. I don't have residents, registrars, fellows. In the United States, it's pretty much your private practice surgeon, and you have your first assistant, usually a physician's assistant. Sometimes we'll have medical students, but it's me doing the surgery from skin incision to capsular closure. Okay. The Navio time is from when I put the sensor pins, the arrays to hold the sensor arrays into the bone, to the time I remove those sensor arrays. So that's what I define as Navio time. Because, you know, somebody can stand up here and say, it took me 15 minutes to do that Navio total knee. Okay. How did you measure that 15 minutes? Okay. Somebody says it took me 92 minutes. How did you measure that 92 minutes? So it's only fair that we define these numbers, because otherwise people are going to get the false impressions of how much time this is going to take in your operating room, right? And that's not fair. We shouldn't you know, set you up for disappointment, if you will. So Navio time, so just the robotic time, is broken down in 10 case increments. And what I would point out to you is that right around the 40 to 41 case number is that there was a significant drop, and then again between 80 and 81 there was another drop. So I called this yesterday a bimodal learning curve, is that you get comfortable with the new technology, and you know what the computer screen is giving you as far as information and how to interpret that, how you respond to that, and then start to use the Navio and the software to your full advantage takes another 40 cases, okay? So you do have to be patient. That's the main message. And as I mentioned this morning, do yourself a favor, don't give yourself the most challenging case on case number 1 or 2 or even 10 for that matter. You know, get some of the simpler cases underneath your belt. That's the same way I was taught to do direct anterior total hip arthroplasty, and it's advice that I've used very effectively in my operating room. So that's the first 100 cases with Navio time. That's what the graph looks like. A nice, steady, slow decrease in time commitment, okay? So that by the end of case number 100, we were using Navio time about 26 minutes, 25 to 26 minutes. Okay. That doesn't mean that it was 25 extra minutes, mind you. This is the time that it took me to basically execute the plan both on the computer and on the patient. So again, there's that graph. Let's go to surgery time, skin incision to capsular closure, and again, very consistent bimodal changes right around case 40 and case 80 in terms of the drop in time. Okay. So in a graph, almost identical. Let's put those two graphs together, and you see that they mirror each other, that as I got more efficient with the Navio and then understanding the hardware, understanding the software, that my time commitment went down, my stress level went down. So to me, as I've continued to measure this out, you know, in the second 100 cases, I've kind of plateaued, admittedly. But what does that look like? So I said, okay, let's go back and look. How long did it take me for my last 50 conventional standard instrumentation compared to these first 200 robotic-assisted total knees? So here are the numbers. I took the first 40 cases out. Okay, that was my initial learning curve. I needed to learn the technology. When I finally felt like I knew the technology and was relatively efficient, the average time for me was 59.8 minutes compared to 51.7 before I adopted the robotic-assisted technology. What does that translate to in my OR? 8.1 minutes of extra time. If I can commit 8.1 minutes, that's, you know, not a whole lot of time, and if I can walk out of that OR knowing that I've done a better total knee replacement for my patient and they have a better chance of, you know, answering their patient-reported outcome scores in a positive way, 8.1 minutes is time well spent. That's the way I approach it. So that's the efficiency data. Let's look at the efficacy data, which is in evolution, as I like to say. So we have multiple studies going on looking at our Navio data, just like the center here in Pune. I would point out to you that our length of stay in the United States is very short. Okay, I've been doing unicompartmental knee arthroplasty as an outpatient surgery for the last 12 years. That's the standard in the States. I'm not the only one doing it that way. My colleagues, you know, in my hometown, we send our unis knees home the same day. We just tell them ahead of time, you know, you're going to have the surgery in the morning and you're going to go home and be home by lunch. Okay, it's a psychological thing, but the same thing works in total knee replacement. Sorry, the slides are jumping ahead here. In that we tell the patient you're going to be in the hospital probably just overnight. If there are any issues at all with physio or medically, pain management, you might stay a second night. That's how we set up our patients psychologically. So before I adopted Navio, my length of stay was 1.8 days. And since we introduced Navio for our total knees, we're down to 1.3 days. So that means literally 70% of my patients go home the day after surgery. Okay, that does require some increased preparation, things that, you know, you can't get done in one day in the hospital, but we do those things as a routine, and it's just part of our routine preoperative practice. As far as positioning of components, again, I haven't quantified it as nicely as the Pune group has, but we have no tibial components outside the 3-degree safe zone. We have no cases of femoral oversizing. We're looking at the how accurate is the burr technique, which I demonstrated this afternoon as well, that if you do your distal burr, is your executed plan as accurate as what the computer tells you it's going to be? So we just very simply lay the mushroom up against the distal burr surface. This keeps jumping forward here, I apologize. And we see how accurate it is. And the initial data, again, is we're less than 1 degree off and we're less than 1 millimeter off. I'll be able to quantify that a little bit more as we delve into that data deeper. We then look at the predicted versus postoperative femoral flexion, as well as the tibial slope. That's data that I haven't collated thoroughly, but we're looking at that as well. We're looking at limb alignment. That's part of an ongoing study that Smith & Nephew is sponsored, and we're part of a multi-center study. It's going to be 120 patients looking at limb alignment. I can share with you that there is not a single case of the first 20 that we've done where that's outside the safe zone of limb alignment. Soft tissue releases was the other one right there. Again, we're just looking to see if the incidence, the number of cases that we have to do any type of significant soft tissue release, whether medially or laterally, what does that incidence look like? What percentage of cases is that? Right now, I can share with you that's about 30% or less of more cases that need soft tissue release after we've gone through the gap balancing protocol. This is the other study that I think is going to really be interesting to see if it makes a difference, because this is the patient-reported outcome study. And I just happened to start about 4 years ago collecting data prospectively. I have an outside entity that does this, looking at the outcome scores. And I started when I was still using Genesis 2, obviously without Navio. We then transitioned to Journey 2 before Navio became available, and now we have Journey 2 with Navio. So we're ultimately going to have 3 cohorts of patients. We don't have the length of data yet to actually get all the data accurately, but I think this will be very powerful data, because if I can show that my Gen 2 knees had an 82% satisfaction rate consistent with the literature going back 10 years, and Journey 2 improved it 2%, and then the addition of Navio perhaps improved it 3 or 5%, and maybe our satisfaction rates are 90%. That's what in my gut, the numbers are telling me based on what the patients are telling us. That's very powerful data, because that shows that updates in component design make a difference, and updates in technique make a difference. And that's what, that's what people really need to know, whether that's truly what's happening. So again, there's so much data on the computer screens that's coming at us. I would encourage any of you that are already using Navio to collect this data. We need multiple centers, not just 1 or 2 centers, collecting data, analyzing this, and showing that things are truly accurate, which means consistent for the case that we're doing right now, and precise, which means case after case after case. So each one of these screens has data that we can collate and collect and analyze. Won't go through each one. I think you guys know that. But this, at the end of the day, is how we want our knees to be balanced. And I hope you guys saw that we were able to do that this afternoon with our live surgery, that we had a very stable knee. It felt stable throughout the entire arc of motion, especially mid-flexion, not just 0 degrees and 90 degrees. So this is a graph with gentle stress on the knee, however you choose to apply that, where you see less than 1 degree of laxity medially and laterally throughout the entire arc of motion. Okay. So what's the future hold? Well, this is one study that came out earlier this year in Journal of Arthroplasty, looking at New York State, the incidence of, or the penetration, if you will, of robotic-assisted technique, that there was access to robotic-assisted technology in 16% of the hospitals 10 years ago, and in 2015, so that was before Navio, it was up to almost 30%, and the percentage of surgeons that are embracing this went from 6.2 to 17.1. So this is pretty powerful. Like I said, this was really just Mako data. Maybe some RoboDoc data, but just Mako before Navio was really creating a footprint in the United States. So it tells you where the future is going, is how I interpret this data. And again, we may or may not recognize, but there are over 4,000 surgical robots across the globe as of 2016. 750,000 operations, and I'd be willing to bet if we looked at 2017 data, that's probably up 10+% at this point. I'm sure the folks who are doing all the development at Smith & Nephew can corroborate that. So, for multiple reasons, I see the evolution of robotics as just continuing to advance and continuing to make further steps helping us in our operating rooms. So this was Brian Parsley's editorial once again, where he basically, his conclusion was literally robots are here to stay. He sees this as the wave of the future, the smartphone of the future. So I'll leave you with the final quote: change is difficult, but obsolescence is worse. Thank you very much.
Thank you, sir. That was a really informative session.